Board for the Norfolk and Waveney Health and Care Partnership. I'm Patricia Hewitt and I'll be chairing the meeting today. I need to start with a few housekeeping points. The meeting's not being broadcast live, but it is being recorded and it'll be available to watch on the Partnership's website after the meeting. The agenda and all the papers for the meeting are also on the website, and the address is www.norfolkandwaveneypartnership.org.uk. This is a meeting held in public. It's not a public meeting, but I'm delighted that so many people have joined the meeting to watch it live, including colleagues from primary care, social care, mental health, acute hospitals and others, and including some of the trust governors. You're all very welcome. We'd be most grateful if you could just turn off your microphone and camera during the meeting. You're also welcome to ask any questions about any items on the agenda. Some questions have already been received and we'll come to them at the appropriate point on the agenda. If you want to, you can also raise questions by email during the meeting, and the email is nwccg.communications@nhs.net. If the question relates to an agenda item for today, then this will be read out during that item or at the end of the meeting. If possible, we'll answer your question today. If necessary, we'll reply by email within 7 days and also post the answer on our website. Any questions that don't relate to the agenda items will also be answered within 7 days and displayed on the website, but won't be read out in the meeting. Finally, because the meeting's recorded and will be in the public domain, we'd ask you not to share any personal information or information relating to a third person if you're asking a question or requesting any clarification. This is a big day for the Norfolk and Waveney Health and Care Partnership. It's our official launch as an integrated care system, one of the 40 or so such systems across England. I just want to congratulate and thank all the members of the Partnership Board, all our partners, our stakeholders, for the work that you have put into making this happen. The COVID pandemic, as we know, has put an enormous strain on everybody over the last year, but most of all upon the people working at the front line of the NHS, in social care, and in the voluntary and community sector. And I think everyone's response has been extraordinary. And as we'll hear in more detail shortly, it's also hugely strengthened and deepened the team working across the whole of our health and care system. The background to becoming an ICS is in the slide pack that's been circulated with the agenda. It's available on the website. It includes a summary of the principles and behaviours that we've developed as a partnership, and of course we'll continue to develop and build on them as we become a statutory ICS. The slides also summarise the recent white paper on integrated care systems. We expect the legislation to be introduced in June, and from next April, integrated care systems will be put onto a statutory footing. I hope you found the slides useful, and I'd really encourage board members to share the slide pack with your boards and governors, indeed with anyone who might find them helpful background. Because of the changes announced in the white paper, and also because of the demands of COVID and the vaccination programme, we are an interim partnership board. In the coming months, we expect to see more guidance on the new structures that will have to be put in place for the statutory ICS. So once we've got that guidance, we'll consider what new structures need to be put in place from April next year, and all our partners and key stakeholders will be fully involved in that discussion. All of us are here because we want to make a difference for people in Norfolk and Waveney. The partnership working that we've been developing over many years is already improving the way things work. And now that we're established as an integrated care system, we'll have even more opportunity to make our contribution to the health and wellbeing strategies that have been agreed for Norfolk and for Waveney. Thank you. That was just by way of introduction, but Anoop, as chair of our Norfolk and Waveney CCG, I wondered if you'd just like to say a few words.
Thank you, Chair. My name's Anoop Desi. I'm a GP and I'm chair of Norfolk and Waveney Clinical Commissioning Group. And I would agree with what the chair said very much, that this is a really important day as our first meeting of an integrated care system partnership board. It's a very important step in what has been and is a long journey, one which I would characterize as being evolution rather than revolution. And it's very much a move from where we were years ago with what was designed to be a competitive environment of organizations which worked pretty much independently to one where we very much want to encourage collaboration and integration. And the journey started probably about 5 years ago with the Sustainability and Transformation program, and was detailed in the long-term plan just 2 years ago. And more recently, the white paper reinforces really some of the strategy changes that are required to make us work and to encourage us to work more collaboratively together. And I think it's in the pack that's gone out with the papers, but just the fundamental approach, I think, needs to be highlighted, the difference from where we were to where we need to be. Particularly, I think for me, it's a recognition that was outlined in the long-term plan and the most recent white paper, that the recognition of the importance of all the determinants of health and social care, very importantly, to integrate social care with healthcare, and the look at population health management, and particularly for me, the focus on prevention and providing services within primary and community care, looking after patients that we know will be increasingly older and more frail with comorbidities, and the necessity really to provide those services seamlessly in the community. And just a quick pointer to what the CCG's role has been. So we've been very much central to that, and last year you'll be aware that the 5 CCGs merged from 5 clinical commissioning groups into one strategic commissioning organisation last April, and we've seen ourselves as being central to bringing organisations together to work more collaboratively within the system. So we're very much looking forward to in this coming year to including through this forum to make sure that we're working much more collaboratively and in an integrated way. Thank you.
Anoop, thank you very much indeed, and thank you for all the work you and your colleagues at the CCG are doing. Now, the terms of reference have been included in your board pack. We need to approve those, please. Is everyone content that we approve? I should just say, actually, those terms of reference were based on the terms of reference that we had on the oversight group that's been in existence for several years. They've been updated, and they're a bit more formal because they need to be now that we are an integrated care system. But obviously, they're only for the interim period until we put the new statutory arrangements in place. Is everyone content to approve the terms of reference?
Agreed.
Thank you very much indeed. Those are approved. Under the terms of reference, we do need to appoint or elect a deputy chair. We don't actually need to do that at this meeting, since obviously I'm here and chairing the meeting today. So can I suggest that we put that on the agenda for our next meeting in public, which will be in June. We now come to apologies. I have 2 apologies, one from Mari Gabriel, but Pip Coker is here, of course, in her place. And we also have an apology from Tony Goldson. Declarations of interest, those are recorded on the website, and those will of course be kept up to date. So those just need to be noted at this point. We now come to my update, and as I always did for the oversight group, I've done a written report just of what I've been up to. That's in the board papers and on the website. Are there any questions or comments on my report? No, thank you very much. That can just be noted. And we now come to our executive leads update. Melanie, let me turn to you to introduce that.
Thank you, Patricia, and good morning, everyone. It's really good to be here, our first meeting held in public. My report, like Patricia's, is really just an overview. It's not commenting on any one particular organisation or sector. It's talking about the priorities that there are within the integrated care system as I see it at the moment. So I've talked about the white paper being published and the work that we'll be doing over the course of the next year to become an ICS subject to successful passing of the legislation. What's significant is the 21-22 planning guidance has come out. This is very different to what we normally expect, of course, and also our financial envelope that we'll be working within. It's very different because we're working in such constrained conditions with the pressures of the last year, but also what we're facing this next year. I've mentioned briefly system pressures, but of course there's a much deeper report on the pressures within the system, talking about hospitals, general practice, ambulance service, 111 and mental health. And my colleagues Josie Spencer and Denise Smith will come on and talk about that. And then there's a separate report about that separate section on vaccination as well. I've also did take the liberty to just highlight the fabulous leadership summit that Patricia and I were invited to at the Queen Elizabeth. I'm afraid Queen Elizabeth, you're the only organisation that's got a shout out in my report. It was a very special leadership summit, and I did just want to highlight that. So thank you, very happy to take any questions.
Great, thank you very much indeed, Melanie. Let me come first to Neville Hansom at the Ambulance Trust. Neville.
Yeah, thanks very much. I recognise, Melanie, that you're not going to mention every organisation in the partnership, but I just wanted to check that operationally you're getting a feed in from the Ambulance Trust that you're happy with.
Neville, there's a much deeper report on system pressures, and my colleagues will talk more about the way we're working together as a system, including the ambulance service, which is mentioned specifically in that report. I want to highlight just the most recent Easter bank holiday weekend, which has traditionally been one of our hardest periods for the whole system. And operationally, yes, we have a very strong feed in from the ambulance service. Without that, we wouldn't have managed to manage the pressures and look after people in the way that we did over this last weekend. I think it was extremely hard work. Particularly for people working in the front line. It was very, very hard. There'd been intense planning that had gone into that bank holiday weekend, but I think everybody was relatively pleased with how things went. Never perfect for everybody's experience, but I think compared to some bank holidays, it was very good. And I just use that as an example, Neville, to reassure you that we have a very strong feed in from the ambulance service operationally.
Good. Thank you. Perhaps the other thing I can mention, Neville, in that context is the, I think, really significant impact there's been now that we've got paramedics having access to the key information they need from GP records. So that I took the advantage of an interview on BBC Radio this morning to mention this. They can actually, they've got the information they need when they go to somebody's home to deal with a crisis, instead of going in kind of cold as they used to have to in the past. And that seems to be having a really good effect on the quality of care and the quality and speed with which paramedics can make the right decision. and then, of course, move on to the next person. Are there other comments or questions on Melanie's report? No? All right. Well, Melanie, thank you very much indeed, as always, for your report. We are doing extremely well on time. We'll now come to our main agenda. And the first item, as Melanie indicated, is the pressures that the whole system is facing. And I'm delighted to welcome two of our executive colleagues, Josie Spencer, who's the Chief Executive at Norfolk Community Health and Care Trust, Foundation Trust, and Denise Smith, who's the Chief Operating Officer at the Queen Elizabeth. It's really good, Josie and Denise, to have you here. Look forward very much to what you've got to say. Obviously, everybody's seen and read the slide pack or the report that you helpfully circulated, but just call out what you see as the main issues, and then that'll give Partnership Board colleagues a chance for comments and questions.
Good morning, Patricia, and thank you. I'm not entirely sure that Denise has joined us yet, but I will make a start, and then hopefully, as I get towards what I'm going to say, at the end of what I'm going to say, Denise will join us. I know she was up against it this morning when I spoke to her earlier on. I'm sure she'll be with us shortly. So we are a little ahead of time, aren't we? So thank you very much. And
I think it's a reflection of the operational pressures.
Yeah, absolutely. But I can make a good start, Patricia. It's not a problem. So first of all, a bit of an apology for the length of the paper. We wouldn't normally pull together papers that are 13 pages long for a meeting such as this. But to be honest with you, when I, through Chris Williams, who helped me pull this paper together, when we asked for input, there was quite a lot that individual organisations wanted to be noted. So we thought we'd give you a fairly detailed paper and overview, but as Patricia said, don't worry, I'm not going to go through that line by line. What we're trying to show is, I guess, as a system across health and social care, showing the challenges that we're going to have as we move through the recovery stage of the pandemic. I will draw out a few key highlights, and then when Denise joins us, she will do the same. Denise and I are obviously very happy to answer any questions. I'm not going to pretend I'm an expert in every aspect of this paper because I'm not, but we'll do our best to answer those, and obviously any we can't answer we will bring back to you through Patricia and Melanie if that's not if we're not able to do that today. So I'm going to touch on workforce, which I think is a really important issue. I'm going to touch on discharge. I'm going to also talk about the changes to the community response, moving towards a 2-hour response time, which is part of the planning guidance that Melanie's already alluded to, and then I'm going to briefly touch on mental health. And when Denise joins us, she will pick up urgent care, elective challenges, and the ambulance, working with the ambulance service as well. So hopefully that will give you a flavour. It doesn't cover everything that's in the paper, so as I say, happy to pick up any aspects outside of that. So first of all, we're going to start on workforce. And for those of you that have had the opportunity to read the NHS planning guidance that came out on 25th of March, just over a week or two ago, the first priority in that document is around managing the health and wellbeing of our staff and our workforce. I think we would be remiss to think that we've only got a workforce challenge because we've been through a pandemic. That has made it worse, I would say. But if we look back prior to the pandemic, and certainly some of the work that the King's Fund have been doing, we had a workforce issue way before we started the pandemic, with vacancies that we couldn't fill, staff feeling that they hadn't got the support they needed, and other such issues. So what we really need to do moving forward is to learn from what we've done in the pandemic, but also to think about how we might think about new roles, how we might support new people to come into the workforce. We are very lucky at the moment from a workforce point of view in that the NHS in particular has become an attractive proposition, more of an attractive proposition for many people, and we are getting a lot of interest in our vacancies. But on the flip side of that, we've got a workforce that is very tired, that has had a lot of challenges through the last few months, and that we need to think about how we support, and we're doing a lot of work about that on that. There is the potential for at least 20% of our workforce potentially could retire at this point, so we do have potential for a problem there. So all the work that's described in the paper through the pandemic and going forward is designed to support develop our workforce with new roles, working across social care. We have a people board, as you probably know, in the ICS that I chair. We have a director of workforce, Anna Morgan. That people board has a broad section of individuals on it, including social care colleagues, including obviously higher education, our staff side colleagues, etc. So a really good board with a lot of work to do. But you'll see within the paper outlined the sort of things that we're trying to do to support our staff. One of the big challenges is going to be around flexible working, and the people plan certainly talks about flexible working, and clearly for many of our services that run 24/7, that is going to be a challenge, but we do have to embrace that. We have to think of using some of the ways that we've worked in the pandemic using technology. We've had clinical services run through virtual working arrangements. Those sorts of things may become useful to us in the future. So lots to do about workforce, lots of things that we need to think about. And I think we're going to have some challenging times ahead. I then wanted to touch on discharge, which is a big section of the paper and links in with our colleagues again in social care. During the pandemic, we have appointed a discharge director, Nick Pike, who many of you will know, been working across health and social care. We've got a real challenge in the system in terms of maintaining discharge pathways. We have, I think, if I'm honest, I also have chaired the urgent care board for a number of years in the system, and whilst we talked about discharge to assess for a long time, I think it would be fair to say that we probably haven't fully embraced the concepts and then implementing that into practice. We really do need to do that now, and we have pulled together a piece of work that has really looked across health and social care processes, has tried to streamline where we can, reduce bureaucracy, and we've now got what we call our blueprint for discharge that all the partners have signed up to. The challenge now, of course, is implementing that in practice, and it's become really important moving forward that we do that, given the pressures that is going to be on the system in terms of unmet demand and achieving reducing waiting lists, etc. On top of that, we have got some new developments in community services. So we, if you recall, back in 2019, became an accelerator site for the Ageing Well programme. One of the main thrusts of the Ageing Well programme, again, it's a health and social care approach, is to have a 2-hour response for patients that require assistance in the community, and a 2-day response on discharge for reablement. The 2-hour response is now incorporated in the priorities again in the planning guidance for this year, and we're well placed, having had the accelerator site for the last 18 months, to develop and move on that quite quickly. One of the challenges I think we're going to find both with discharge and with the 2-hour response in the community is that many of those services during the pandemic have been manned by individuals who have been redeployed from other services whilst those services weren't running. So we are going to have to look at the workforce implications of making that more mainstream into the future. There's a large section on mental health in the paper that I wouldn't want to detract from the importance of. We've got some real challenges in mental health. I know our acute colleagues are seeing more mental health patients actually in the acute sector. I know there's some challenges with NSFT working really hard to ensure that the right mental health offer is there for both adults and young people. And certainly through Melanie as the Chief Execs Group, we've got a piece of focused work to look at how we're going to manage that going forward. And I think it's an unmet demand that's going to increase, and I know that that's been recognised nationally as well. So they were the key areas that I was going to speak to. I'm just going to see if Denise has joined us. If not, I can start to talk a little bit. Are you there, Denise?
Hi, Josie. Yes, apologies. I was there for the beginning, sorry, but I appreciate people didn't see me, but I'm pleased to say I've heard all of the first part.
Denise, welcome. It's a real pleasure to see you, and thank you for making the time. So over to you.
Thank you very much. So I will briefly take us through urgent emergency care and elective care system pressures. Again, as Josie said, I'm not proposing to go through the detail of the paper, but we'll just pick out some key highlights. So across the entire urgent and emergency care pathway, I think all the acutes and the ambulance service saw a very, very similar picture through wave 1 and wave 2. So in wave 1 of COVID, we saw a really sharp decline in our ambulance service arrivals to ED and our walk-ins to ED. So that demand dropped off very, very quickly. It then did pick up between wave 1 and wave 2, but didn't go back to the same levels. However, as we're coming out of wave 2 now, we're all experiencing a significant increase in demand, particularly since we've seen some of the lockdown pressures eased, and we've got our ambulance arrivals are pretty much back to pre-COVID levels, and our walk-in patients are actually over and above what we were seeing pre-COVID. And we know that in Norfolk and Waveney, as we see the summer period approaching us, we're expecting and planning for that sustained increase in demand, and possibly more so than we may have had last year. So that it has been a very, very different picture. Some of the things that we have been working together on through COVID and retaining beyond are working closely with our ambulance service colleagues to really look at alternatives to arrival to ED. So there's been some really good work done around alternatives to conveyancing. If I just pick up on a couple of examples, there are examples where we can offer phone call to ambulance service crews so that we can either safely keep patients at home if we can provide the right clinical conversation, and we've been able to put things like a frailty phone, for example, into the Queen Elizabeth 7 days a week, so the teams can have that direct conversation with a consultant geriatrician and safely not convey patients. So there's been a lot of positive work that we've done together that we can build on, and we absolutely plan to retain all of that in a post-COVID world. One of the challenges that we have all faced is how we manage the suspected COVID and the non-COVID demand through that emergency pathway, because we've all got limitations on our emergency care estates, some of us more than others, and we absolutely have to be able to stream those patients differently. And we fully expect that this is something that we're going to have to manage for certainly the medium term, if not the longer term. So we've got to adapt how we use our estate and our workforce to be able to safely stream those two sets of patients. If I then move on to elective care, the good thing through the last year is that we have all maintained all of our urgent emergency care and pretty much our cancer care services. So that has been good, and we have been able to maintain that minimum level of service. The thing that clearly stopped in the first wave of COVID was all of our elective care services that were routine. They were all paused, and we're all really focused now on restoration. And restoration has to be balanced with health and well-being of staff, but equally with that patient need and patient demand, and stepping services back up as quickly as possible. As expected, we have all built up a significant waiting list, and there is a backlog of patients. We're working really closely together as a system to make sure that we have that clinical prioritisation in a really consistent way, so that we need to make sure that all patients have that equality of access to services, and looking at how can we maintain that across the entire patch. We're seeing that we've gone from having no patients waiting over 52 weeks for elective care to significant numbers of patients who are beyond 52 weeks. And the prioritisation at the moment remains on those patients who are clinically urgent, so patients who need to have their surgery within 4 weeks, whether they're cancer surgery or other clinically urgent surgery. And then after that, we're all prioritising those patients who have waited the longest. And there's a really robust process in place that we are all mirroring, which is about reviewing regularly patients on that waiting list, that clinical review, and making sure we have an up-to-date picture of the prioritisation for each individual patient. It is over and above what we were doing before, but it's imperative that we can all have that clinical oversight of the waiting list that we now face, because it's a very, very different picture to pre-COVID. We've also done some great transformation. We have probably been able to take what would have been a 2-year improvement programme around outpatients. We did it probably in about 2 weeks, and we rapidly introduced remote consultations, whether that was by telephone or video consultation. The patient response to that has been incredible, and I think pre-COVID there was possibly some assumptions that maybe our older population wouldn't want to do video conferencing or telephone consultations. It's been so well received, and actually not having to bring patients to hospital, not having to try and get parked, pay for car parking, waiting in waiting rooms. It has gone down really, really well, and our clinical teams and our patients have adapted to that brilliantly. So we're keeping the learning from that, and we fully expect going forward that this will be something that is much more the norm now. So out of all this situation, lots and lots of positive and some really, really good system working. We work much more closely together week on week than we ever probably did previously. I'll pause then. Happy to take questions.
Thank you both very much indeed. That's been incredibly helpful. Right, let me start with Billboris, then Anna Davidson, then Anoop Bessie. Bill.
Thank you very much, Chairman. I'm Bill Borrett. I'm an elected councillor and I'm chair of the Health and Wellbeing Board for Norfolk. I just wanted to pick up a couple of comments. When we talk about workforce and our workforce, of course, we're not just talking about the NHS. We're talking about the private providers in the care market, and we're talking about the social care of the county council. So that we have everything from public employees to private employees across a large and complicated system, which is what we're talking about here, system pressures. And I just wanted to say that I think that the care market, the private provider, have really risen to the challenge. They've had a very tough time, as indeed have we all over the last year and a half. And I just wanted to bring particular attention to their contribution, and also to voluntary groups and the district councils in their role of pulling together local communities to help and support. But I do think workforce is a pressure for all parts of the system, and I wouldn't want us to see us. I'd like us to see a policy across the whole of the system, so that we didn't end up recruiting into one area of the system at the expense of people moving from another part of the system. So I think that is a key issue for us to look at going forward. I wanted to, one of the things we're asked to do is to consider if there are areas we'd like to focus on in greater detail in the future. I was particularly pleased to see the mention of discharge to assess, because I think that is a key area going forward, and one that we have talked about for many years. And it was very positive to hear Josie's comments about the joint working with that going forward. I think there are going to be issues going forwards with financial pressures for the adult system in social care to support this, and I think that's something as a system we're going to need to consider. There isn't yet a national strategy or solution for the pressures in the social care side of the system, where there has been acknowledgement from central government on the NHS part of the system. So I think that is going to be something that we need to consider going forward. But I really do support this closer working, and I'm hoping that we can get some real traction on that. There has been an announcement of 6 months more money to help support this from the government as part of the COVID monies, but that doesn't give us a long-term solution.
Bill, thank you.
Thank you very much.
And yeah, I think it would be hugely helpful when we get the social care plan from the government to complement the plan that we already have for the NHS itself. So Anna Davidson, then Anoop, then Tony Osmanski, then Geraldine Broderick, and keep comments and questions tight if you can, conscious of time.
I will do. Good morning, everyone. My name is Anna Davidson. I'm the chair at the James Paget University Hospitals over in Galston. I wanted first of all to thank Josie and Denise for their report, which did pack a lot of information in but it was very easy to read, and I think it covered all the main points. So thank you for doing that. One of the things that I would like to ask is that we hear a little bit more through this ICS board of the progress of the particular people board, I think it was called, the workforce board, so that we can know, if you like, about the system approaches that are being made and complement those locally within our own organisations. I'm sure it is disseminated somewhere, but at the moment the specific projects that are being worked on and the progress that's been made is not particularly visible at my level, if you like, within the trust. And I think it's really important when we're setting our objectives that we understand and as I say, seek to complement, because I'm sure they're all very worthy and very good projects. It's just we would obviously want to make sure we do those locally within our own organisations as well. So it's a plea really to do that in some way.
That's great, Anna. My understanding is a lot of this is built up from below, from the partner organisations, but let's see if we can get Anna Morgan to give us a much fuller report on the people board work. Perhaps at the June meeting we can have a look at future agendas. Anoop.
Thank you, Chair. Anoop Desi, GP and Chair of Norfolk and Waveney CCG. Firstly, I wanted, as Anna has done, to say that I think it's a really good report and to thank Josie and Denise for presenting what, to me, I think represents an accurate position of where we are currently coming out of the pandemic, hopefully. The couple of points I wanted to make relate to what is in the report on recovery and restoration. And in particular, I want some assurance around the involvement of clinicians, clinical engagement in being involved in that work on both recovery and restoration, and engagement with patients as well. Mm-hmm. So specifically with recovery, we've got some of the figures which show the pressure in terms of the waiting list, how it's gone up. I know that within the CCG we had a discussion with clinicians about some of the initiatives to help to go through that list, because I think it's quite sort of concerning that there's such a large increase in waiting lists, and these are patients that often don't know where they stand. So I think it's really important that we work with clinicians in primary and secondary care to systematically go through that list, to hopefully get reassurance from patients as to their conditions, whether they've improved or deteriorated, and act accordingly based on clinical need. And that's on recovery. And just a final question and plea on restoration as well, is that we've had some really good examples, and Denise mentioned about outpatients being transformed within a matter of weeks, what had been envisaged to take a couple of years in the long-term plan. And just a plea really to all partners to make sure that we don't, in talking about restoration, we don't restore things to how they were, because I think that will be the natural tendency to think that we can switch services on and they need to be how they were. And I think we just need to recognise that demand is already going up, and that's predictable. And in doing things differently, particularly in using online consultations and digital technology generally, we have transformed services to a large degree, and we must keep the best of that transformation as we go forward. Just as an example, in general practice, there have been many issues, but we've been using in general practice much more online consultations, which have actually made us more accessible, particularly to younger people and to working people, which we want to continue. If we switch on services as we did before, there wouldn't be the capacity, and I would say it wouldn't be desirable to work as we did before. So again, just going back to clinical engagement, can we please make sure that we work across the system to make sure that we truly do transform and commission transformed services going forward, and that they don't just happen by default. Thank you.
And I'm going to come back to both Josie and Denise at the end, because I've got a lot of people wanting to make a comment or ask a question. But Melanie, did you just want to respond particularly on that issue of clinical and patient engagement?
Yes, thank you, Patricia. Anoop, I absolutely agree with you. It's essential that clinicians from the whole system, primary care, our GPs, and also the acute and community trusts are involved in making plans and the decisions around how we restore. Absolutely agree, not as they were, but so that we can recover and actually maximise the transformation that's happened over this last year incredibly successfully in many ways. The two groups of the STP, or the ICS as we now are, that are responsible for leading this are what we call the Clinical Care Transformation Group, which the name is on the tin. It's a group of clinicians co-chaired by Erica Denton, the Chief Medical Officer from the Norfolk and Norwich, and Dr. Hilary Byrne, a GP from South Norfolk, and it is made up of clinicians from the system. The other group that gets into more operational detail, but also includes clinicians from both general practice, primary care, and the acute system as well, is the System Planning and Transformation Group. Those are the two groups that report into the ICS executive, and then this group that will be making those decisions. That's not to say that those are the exclusive areas where the discussions take place. These are really important issues. So there'll be discussions and socialisation of what we do outside of that. But that's where the leadership and the decision making comes from. And in terms of patients, absolutely, it's essential that we listen to patients about what is going to work best for them and their communities. And we have very strong support from Healthwatch Suffolk and Healthwatch Norfolk with conducting many surveys. We're going to hear later as well from Simon and Bernard Brett around the clinical strategy and how we're involving and listening to patients in terms of the future planning for the clinical strategy as well. But I absolutely agree with your points there.
Great. Thank you, Melanie. Now, quick points, please, from Tony Osmanski, then Geraldine Broderick, John Fisher, David White. Tony.
Yeah. Thank you, Patricia. Good morning, everyone. I'm Tony Osmanski. I'm chair of East Coast Community Healthcare, or EC, as we're more locally known. First of all, excellent paper. Thank you, Josie and Denise. I was really pleased to see the focus on workforce pressures. We owe a debt of gratitude to all of our staff, whether they're in health, local government, or the independent sector. And I think that part for me of the report was the most crucial. At EC, we've recently carried out a really comprehensive survey on staff, asking them about their reflections on the last year. We've been fortunate to use the outgoing chief executive, who's been able to go and speak to them personally in groups, and we've captured a lot of positive. There's been so much positivity around camaraderie, not just within EC, but working within colleagues across the system. But there's also been highlighted, as I'm sure will be the same in colleague organisations, a number of challenges, and we've asked how we could have provided better support. And we're going to use those results to try and drive future improvements in our workforce support. And so my question, Patricia, to Josie, and it's building on from Anna's question earlier, is I wonder if the People Board could coordinate survey results, because I'm sure this has been undertaken in other organisations from across the system, so that we can share the learning in terms of future support. Thank you. Oh, and Patricia, in a moment, I'm just going to have to leave the meeting for 5 minutes. I'm a family carer. I've got a caring issue to see to, but I'll wait for a couple of minutes.
Thank you, Tony. Geraldine.
Good morning. I'm Geraldine Broderick, Chair of Norfolk Community Health and Care. Also like to just register my thanks to Josie and Denise.
My apologies. Can you switch your camera on, or do you have a bandwidth?
It's on. Sorry, it's on. Yeah, sorry about that. Mine's only a very brief question. I just also wanted to acknowledge Chris Williams in there in pulling together the report, which I think is absolutely excellent. Just one small question from me, because Anouk pulled out several of the points I had to make, and that is, how are we communicating with patients who have been waiting a long time? It's probably more for you, Denise, because I am hearing noise in the system around me, kind of people saying, I don't know what's happening. And I'm a bit of a supporter of the nothing about me without me slogan. So just specifically, how are we telling patients what's happening?
Thanks, Geraldine. John and then David.
Morning, thank you, Patricia. I'm John Fisher. I'm Cabinet Member for Children's Services at County Council. Just again to, as other people said, to welcome this report, and I am pleased to see that we do have reference to children in it and children's and young people's mental health in particular paragraph 50, where it does identify that in fact the Norfolk figures are higher than the national mean. And I just wonder whether there's any reason, or whether we have determined any particular cause for this, whether it's better reporting in Norfolk, or whether in fact we have an issue. And I do welcome the fact that it has identified that with the schools returning, we do anticipate an increase to that. So yeah, on both those fronts, if we've got an answer, that would be helpful. But I do welcome the reference and the acknowledgement that young people are now part of the health system. Thank you.
Absolutely. Thank you, John. David.
Good morning. I'm David White, Chair of the Norfolk and Norwich, and there's a lot I could say on this excellent report, but I'll keep my comments really brief. First of all, I think what this really demonstrates is brilliant system working over the pandemic, and if there's ever such a time for the body that's now coming into being, this is it. So brilliant. We've worked really well together, and let that continue. The second point, really, I want to build a little bit on what Anoop said and Melanie. I think fundamentally we need as an NHS, not just in Norfolk, a more honest conversation with patients who are waiting. The Norfolk and Norwich board yesterday, we actually recounted the fact that there's over 60,000 people now waiting to be seen at the Norfolk and Norwich. Which is clinical priority, and it's right, and we are letting the long waiters know by letter what's happening, Geraldine. But fundamentally, the restoration and recovery and transformation is going to be a long haul. And I just think it's the only point I really want to make is that whilst we've got to look at clinical priorities going forward, which is clearly a lot of cancer work, I think we need a broader debate about realistic expectations of what can and can't be done. So we're not unwittingly causing more concern for patients who are inevitably going to have to wait a lot longer than any of us would want.
Thank you, David. Now, I'm just wondering, Denise or Josie, just any quick points you want to make in response?
Thank you. If I pick up, Patricia, the points about contact with patients and the clinical prioritisation. So just to provide some assurance that the National Clinical Prioritisation Programme does require all of us to make sure that A, we are having that clinical input into the prioritisation of all of our waiting lists, but B, we are in touch with patients about that. So we have all been going through that process over the last few months. That will continue, and then where we can't meet the desired waiting times for patients, we then have to do a re-review, a possible re-contact with patients, re-clinical review, and where appropriate, any harm review process for those patients. So there is a very robust national process in place that we are all compliant with, and it is good that that involves the clinicians within the trust, but it also involves patients. And I would just echo David's point that it is really important that we do have that realism that this will it's taken us a year to get into this position, and it will take a long time to recover fully, and we absolutely have to be really open and transparent with all of our patients about what we can and can't do and the timescales in which we can do it.
Thank you, Denise. Josie, any final comment?
Yes, please, Patricia, I'll keep it brief. So thank you for all of your comments. I'll particularly just pick up a couple of the comments around the people and our staff health and wellbeing issues. So certainly as a people board, I'm sure Anna will be able to come back and give you a much more comprehensive update on our work programme. Just to give some assurance, our work programme includes all sectors. We do have the voluntary sector, which actually have a very active members of the ICS people board and a good representatives from social care, both from looking at social care in terms of the the independent sector, as well as obviously our own through local authorities. So we are very keen that we have an approach that doesn't, I think as Councillor Borrett was mentioning, doesn't rob Peter to pay Paul in terms of moving around staff. We want to make it a system approach and have a system offer that individuals find attractive. So I'll take that back to Anna, and we will be very, very happy to provide more detail at a later date, Chair. Thank you. Great.
Josie, Denise, thank you both so much. Really excellent paper, and I thought a very valuable discussion. Thank you.
Thank you.
I'm now turn to Melanie for an update on the vaccination programme. Forgive me, I'm going to disappear from the screen just for a second while I sort out my battery problem.
Okay, Melanie, thank you, Patricia. I know this is, since the first week of December, we've been working on the vaccination programme, and in some ways it seems like it's old news now, but it's still very, very much front and centre and a huge effort across the whole of Norfolk and Waveney from so many people involved. And so it is important that we pay attention to this, and also just to acknowledge that it has been a huge success in Norfolk and Waveney. I have data, the last published data, which is a week old, up until the 28th of March. Today is the day when we'll have a week's more data will be published, usually later today. But so far, 65% of people over the age of 16 across Norfolk and Waveney have had their first dose. And indeed, the first Prime Minister's goal, which is by the middle of April to vaccinate cohorts 1 to 9, so everyone over the age of 50 plus unpaid carers, health and social care staff and care home workers and residents. We've vaccinated 95% of over 50s, and there's a week more data to add into that. So just a massive team effort from so many organisations, volunteers, GPs involved. It's been a huge success. And I'm very grateful, particularly to the volunteers for their efforts in supporting all of our vaccination sites. As people probably know, we're now in this 4-week period where we've had a constrained supply. We're focusing on second doses, but the second doses programme is going very well. And also starting to think and turn our attention to when there's a national announcement to open up into the under 50s age groups, cohort 10, 11, 12, which we haven't seen yet, but we're starting to think about more flexible ways to reach that cohort, that population in a more appropriate way. It will all be about ease of access. What's important now is that no one is left behind. So trying to reach out to lots of different communities and make sure that we get those very last people. There's some great innovation, fabulous innovation going on. Our vaccinating bus that will be run by Norfolk Community Health and Care, leased by Norse with support from Norfolk County Council, will hit the road next week to visit particular communities. We're seeing some fabulous drive-through and walk-in clinics running, reaching people that we had really hoped to reach but hadn't come forward up until recently, and a big focus on the most vulnerable groups and people with poorer health outcomes, reaching them and trying to vaccinate where they are. So those are some of the highlights I wanted to just mention by way of introduction, Patricia, but happy to take further questions.
Good. Thank you very much, Melanie. And I'm sure the whole partnership board would want to congratulate all the teams who've been working on this. It's just a terrific example of successful team working. Geraldine. Oh, no, I think that was...
Sorry, Patricia. It's not a question.
That was a leftover hand. Okay. Anyone have a question or comment? Right. Well, Melanie, I think everyone's just thrilled with the result. So there are no questions on that. And we will move on to the discussion about the system clinical strategy. I can see we have Dr. Bernard Brett with us. Let me check if, and we have Simon here as well. Absolutely delighted to welcome both of them. Dr. Bernard Brett is the Deputy Medical Director at the Norfolk and Norwich. He's also chair of the East of England Clinical Senate, so one of our very senior and eminent clinicians. Simon Hackwell, who's the strategy director at the Norfolk and Norwich, although let me stress it is kind of coincidence that we have two people from the Norfolk and Norwich. This is a system clinical strategy and it's a system-wide team working on it. We had hoped, as the agenda says, to have Dr. Hilary Byrne here, co-chair of the Clinical Transformation and Reference Group, but unfortunately she's had to take leave today, so has sent apologies for this item. But let me welcome and hand over to Bernard Brett.
Thank you very much indeed, Patricia. I'm not going to go through the paper, I'll take that as read, but I'll bring out some key points that I'd like to highlight. So quite rightly, the integrated care systems agreed to develop a system clinical strategy. As we've already heard, we've coming through our crisis response, working on a recovery, but we need to develop a long-term sustainable future. We already had an overarching system plan, a healthier Norfolk and Waveney, and many elements of that will remain entirely valid. The one vision of a healthier Norfolk and Waveney, the three goals about telling my story only once and living it as healthy a life as possible and making Norfolk and Waveney the best place to work. And we already knew about the background demographic challenges of an aging population and, for example, significant obesity rates, which would impact on demand going forward. And we already knew that we had significant areas of deprivation and health inequalities. So the scale of the challenge was already very large, and we knew that we had to do things very differently. But it's entirely right and proper that we should reflect and review on the strategy and develop in light of what we've learned from the pandemic. And just to say that there's lots of work already going on. There's regular meetings, not just between the three acute trusts, has already been mentioned across the system at the Clinical Care and Transformation Group, which I sit on, which has already been mentioned, has representatives from primary, community, mental health, ambulance, as well as patient representatives and secondary care. And many work streams that are going to be relevant to the strategy are already underway. And I might give some examples of some of those things later on. So the COVID pandemic has obviously impacted on virtually everyone in the country, if not everybody, and that has included clinical and care colleagues who've both been impacted personally and professionally. Although many may be exhausted from the response, there still is a real feeling of opportunity that we can look to adopt, adapt, or indeed, if necessary, abandon what we've learned from our response. So we must build on the accelerated innovations in care that in the past have only really been an incremental changes that we've seen, especially to look at technology and continue the progress of collaboration between healthcare settings to help address gaps and meet the needs of patients. Learn from things like, as we've already heard, the successful vaccination programme and the online access to primary care. And again, as already been mentioned, a very real concern about the backlog of patients on waiting lists. Each patient, not just a statistic, of course, they've got their personal impact and story. And we also have to be concerned about those that we don't yet know about, those that are waiting to be seen or haven't presented. And the only way we can tackle these is to work as an entire system. And that's not just the three acutes, which their collaborative working is going to be vitally important, but it's working with our primary care colleagues, community colleagues to try to address that. We've also got the ongoing challenges of non-elective care, which we already knew about, and we can only tackle that with better prevention and community and virtual responses, as well as shortened length of stay. And of course, we need to reflect on the fact that we need to be ready for future respiratory agent pandemics. So we need to build on the existing vision and goals, but what's already emerging that there needs to be even more focus on health inequalities, primary and secondary prevention, mental health and well-being with a mind and body approach, the real need for protected elective facilities, not just protected in case of pandemic, but from emergency pressures with streamlined care to help address the backlog with standardisation and indeed a single waiting list. 24/7 integrated urgent care around people with a single point of access. Digital solutions, not just to help patient-focused solutions, but also more integrated care. population health management to help target resources to improve the outcomes with those with the greatest need, and care closer to home and often now in people's home with virtual technology, with the real need again for resilient primary care and community services. And importantly, all of that has to be with a focus on safety and quality. And the idea is emerging of a quality cell to look at metrics to support the delivery of high quality services across the ICS. And it's really critical that we adopt and adapt the new ways of working. And only by working together across the system, and particularly between the three acutes, are we going to get more resilience, better joined up care for patients, better outcomes and shorter waiting times, as well as better opportunities for staff. And our workforce is absolutely vitally important. So it's an iterative process. We need real engagement with all stakeholders, including patients and the public, as well as staff, to get this right. We need to reflect on the new strategic context and agree the principles, the clinical objectives, the clinical priorities, and what's going to be really challenging is to develop smart outcome measures that will help us really label what we want to achieve and how we're going to measure that we are going to achieve it. And co-production is going to be really important. We might get the high level framework right, but when we get down to those pathways in particular, we need really significant patient and public involvement, and there won't be any major service changes without involving patients and public first. I could give a few examples of some of the really big changes that are already going now, or do you rather open up for questions first, Patricia?
Bernard, why don't you give a couple of examples and then we'll come to questions and comments.
Okay, so Anup has already mentioned the online access for primary care, which has absolutely revolutionised primary care access and meaning most patients get a response within the same day. We've had a huge uplift in secondary care with telephone and video consultations from a very low starting line to some specialties with over 50% of consultations going ahead in this way, avoiding unnecessary travel, better for patients, better for the environment, but of course does require us to think about other things like the greater need for community phlebotomy services. We are very close to agreeing across the three acutes a unified consent policy. And that's just one example of one of the main underpinning policies that we need to make sure that we have the same approach across the system. And that means consent, for example, in one setting will be valid in another setting. And it's part of making that joined up care, telling your story only once. You'll already know that we've got the single EPR project up and running, and that's going to be
electronic patient record.
Sorry, electronic patient record. I do apologise, Patricia, but that's absolutely vital to make sure that we can share the information across the system, and again, avoid patients having to tell the story more than once, but reduce the risk for errors. One of the great innovations that's been introduced during the COVID pandemic, initially in response to COVID patients, and this has been in all three acute trusts, and we're now trying to pull them together, is the virtual ward. And this has enabled us to use virtual technology, including observation measurements such as blood pressure, pulse, saturations in the community. And that means some patients have avoided admission altogether, and other patients have been discharged much earlier while still having very close monitoring. And although this was, as I say, initially used for COVID, this can subsequently be used for a whole range of conditions and will help them meet some of the non-elective demand that we've faced. Yeah. A final example, I think, is we've had a small number of virtual clinics. So where you would usually attend an outpatient clinic to receive information about your condition or treatment, now we can deliver that virtually. And patients, the evidence is that patients find this more useful because they hear other patients' questions around their condition and take more learning from it, whilst it being more efficient in terms of delivery. So I think I'll pause there and open it up for questions.
Bernard, that's great. Thank you very much indeed. Simon, did you want to add anything to that before I come to board members? Okay, thank you. Let me take Steve Barnett and then Billboris.
Thank you very much, Patricia. I'm Steve Barnett, Chairman of the Queen Elizabeth Hospital in Kings Lynn. Thank you very much, Bernard, for the presentation. I think this is arguably the main building block for us to develop a system approach to integrated care, but also I think it is an important piece as we develop place-based integrated care. Because it's such an important building block, I think the need to have really effective engagement, as described in this research piece, is pivotal to its ultimate success. And in that regard, a couple of points. First of all, when we talk about clinicians being a central part of the research, we do, of course, mean clinicians in their widest sense, not just doctors, but all of those who are delivering and planning hands-on clinical care. And secondly, to give this practical effect, of course, a system financial plan has to be effectively aligned with the clinical strategy for the system. And I assume, Patricia, as we develop as an ICS board, that we will seek to align those two important aspects. Thank you.
Absolutely. Thank you, Steve. And already the work that's going on, led by John Ingham, with finance colleagues from all around the system, is very much looking at that alignment. So Bill Borrett, then Geraldine, then Pip Coker, then Anu.
Thank you very much, Chairman. I just, first of all, I'm really glad to see that this isn't about starting again, but by building on the work we've done through a healthier Norfolk and Waveney, you know, the system's long-term plan before the pandemic struck. So this must be about combining what we knew then with what we know now and delivering it within the new context that's coming. My only caveat, or something that we might still need clarity though on how all the different plans will connect, e.g. the ICS goals and principles, the joint health and wellbeing strategy, the clinical strategy, and the NHS 21-22 priorities and operational guidance. So pulling that together into something coherent that makes sense to all the bits of the system, I think is going to be a challenge. And that I just really wanted to mention that, because I think it will be an issue going forward. But that's not to say that all the work that's being done isn't extremely helpful and absolutely vital to where we go as a system.
Good. Thank you, Bill. And we're all hoping, I think, that some of that architecture will become clearer as we get the new bill giving effect to the white paper. Geraldine.
Good morning. I don't think we've met, Bernard. I'm Geraldine Broderick, Chair of Norfolk Community Health and Care, and thank you for acknowledging us in there. And good morning, Simon. I too really look at everything in the pandemic as what do we adopt, what do we abandon, and I think in the history of the NHS, the vaccination programme will go down as being one of the most successful things we've ever done. And one of the things I think very much is how can we adopt almost some ideas from that programme to address some of our clinical backlog in terms of operations. And in terms of integration, I'm looking specifically at, when you talk integration, does that include the private sector? And are we looking at clinical backlogs in terms of what standard? You'll have to excuse me here, Bernard, but I have a bit of a background in manufacturing, and I like to separate standard and complicated, if you like. And I just see it as a way we could address some conditions that aren't complicated, but actually they're high volume. So your thoughts would be very welcome.
Thank you, Geraldine. And I'll come back to Bernard and to Simon, obviously, at the end. Pip.
Thanks, Chair. I'm Pip Coker. I'm Non-Exec Director from NSFT. We've said many times that we will only be successful in this endeavour if it feels different to people. And I suppose, a bit like Steve, I think the research we are undertaking is a unique opportunity to really find out what would be different for people, what would feel different. But it's also an opportunity to ask people how and if they would like to be involved in engagement, to actually build a pool of people who might be interested in co-production, which is an opportunity we perhaps haven't had before. So it's just to urge us to do that. And I know I've said this before, and apologies, because it isn't a big issue, but it is to me. Within the slide pack, table 1, the 10 areas that the strategy needs to respond to, there is something about the order of those things that jars with me. And I think I would just like somebody to have a look at them, because prioritise the mental health of our population at the bottom of a list does say something to me, and I don't want it to.
Yeah, Pip, I think that's a very telling point. So let's take another look at that. Thank you. And Anoop and then Anna.
Thank you, Chair. Can I firstly thank Bernard and colleagues for presenting the paper. I know it predates the pandemic, and I think it's a really important piece of work. I can identify with the objectives, the strategy. I think we would probably all agree with, but as always, it's the implementation that is the most important, because nothing will happen unless you implement things. And I think for me, I'd like to see that we have that we systematically go through those objectives and work out actually how we're going to implement that across Norfolk and Waveney. In particular, I think we've mentioned before some of the examples, and Brett mentioned them earlier, about some of the good practice that's come out of the pandemic and the new ways of working. And I think it's really important that we scale up and industrialize the good practice that we've achieved in the last 12 months. And specifically, I think I'll go back to clinical engagement, and I think it's important to have the clinical care and reference group, which I sit on as well. But actually, you want clinicians on the ground who are interested in particular services to be involved in their transformation, and including co-design. And I think I agree completely with what Pip said, that it's at the point of implementation and planning specific services that you want to get patients involved as well. So for me, the key is what happens next, and for us to industrialize and scale up some of the good practice that we've developed over the last 12 months. Thank you.
Thanks, Anu. Anna.
Thank you, Patricia. I was just going to ask about implementation timeframes. Obviously, whenever you see a strategy, it doesn't mention, as far as I can work out, whether this is a 1-year strategy, a 5-year strategy, a 10-year strategy, and it doesn't crucially say when the strategy itself, when we are aiming to have completed that really important piece of work. So whilst I acknowledge all the stages are complicated and there's a lot to feed into that, I would like to see something much more concrete and commitment to when we're going to achieve some of this, because it's so important for the individual organisations within the system then to kind of use this as the basic block for our own planning and our own objective setting, which obviously we're all engaged in at this precise moment. So what we want to do is to dovetail in and help to deliver these system strategies, most importantly for us, this clinical strategy at a local level. So I'd like to see those timeframes very quickly, even if they have to be amended as time goes on. We need to have, I think, a commitment to those. But also I would like to make a suggestion that the objectives, when we land on them, they need to be really smart and well measured, so that we know that we are making the difference. That thing that Pip mentioned, you know, what will be different when we've done this. And I think it's about how we specify in those objectives, when we know we'll have got there, what are the things that will be different, and having, you know, those clearly targeted with timeframes and responsibilities attached to them. So that's my comment. Thank you.
Thank you very much. And actually, before I come to Bernard and to Simon for comments on that, I'm just wondering, Melanie, whether you might like to just say a little bit more about timescale and how this work, dovetails with other bits of work going on in the ICS. The other thing I thought you might want to comment on was, I think it was Geraldine's question about the independent sector, because obviously during COVID, we were able to use a lot of independent sector hospital capacity, particularly, I think, for treating patients with cancer. And it'd be very useful, I think, for everyone to know just what the plans are for that over the next period.
Yeah, thank you very much, Patricia. I mean, I really want to commend the work that Bernard, Hilary, Simon and others are leading here. It's a vital part of our future arrangements for Norfolk and Waveney. And the clinical strategy initially, we are looking for at some initial drafts in early summer that will then take account of the patient and clinical focus groups that we're going to hold over these next few months. So that will be an important milestone in the early summer. This will then, I guess, also feed into it will be really important for the provider collaboratives that form and our acute systems, also how we work then at place level in more geographical areas. So the clinical strategy is an important foundation for the next 6-12 months and beyond, obviously, of the integrated care system. But that's the first stage. And I should just underscore as well, Bernard did give a number of very important examples of work that is already happening. So we are not waiting for a strategy to be drafted, to be finished, before actually getting on with anything. This builds on work already happening at pace. And as we heard when Denise spoke earlier, Denise Smith, around system pressures, the team working is essential to accelerate all of this. And team working, we build on becoming a more effective team just week after week after week. So it's an upwards trajectory. In terms of the private sector, I think we're really only touching the tip of the iceberg in terms of the opportunity that we can get from working alongside private sector. We have, of course, worked with private healthcare sectors during the pandemic and made use of that. I was particularly thinking about, Geraldine, with your question, around some of the innovation that can come about through working in partnership with industry and outside. And I think that's really important for the NHS and for the ICS to do more of, and with local businesses. Doesn't need to be big firms, big national firms or international firms, but with local businesses, particularly when we're thinking about restoration and planning and the economic impact and employment opportunities as well. So I would really like us to do much more on that front, working with small, medium businesses. We're working strongly with the LEP, with the local enterprise partnership to do that. But I think we've just touched the tip of that really, and there's a lot more opportunity we can get by partnering with the private sector outside of the NHS. I don't necessarily mean healthcare private sector.
Simon, is there anything you wanted to add in response to any of the comments or questions?
No, I've made a note of the comments that have been made, helpful as they have been at previous discussions that we've had. This is going to be quite a tricky document to write because I think a lot of stories being placed into it, and it potentially has a very wide scope. So managing the scope of the strategy is going to be quite an art in itself, I imagine. But we will continue to engage with the clinical and care transformation group as our sort of primary sounding board, but also come back here, Patricia, on a regular basis to keep you informed and share progress, share work as it's produced in draft form.
Thank you. And let me come to Bernard for final comments.
I think they were all very, very valid questions that were put forward. Totally agree that we need all clinicians. We do have all systems represented at the CCTG, but we need clinicians on the ground to have their chance to input to really make it work properly. I totally agree that it's about building on the existing and adopting and adapting from what we've learned from COVID. We have to link in with the NHS priorities and the NHS strategies, but we also have to think about individual organisational strategies and other work streams. Everything's got to be joined up. Integration is really important. Some of the solutions to the elective care has to involve community and primary care. It's not all about secondary care by any means, and I agree about learning from the private sector. Again, another example, we're using an AI private sector firm to try and develop means of looking at how we'd prioritise patients on waiting lists as an example of using the private sector. Another piece of work that's already ongoing to try and reduce the risk of harm. I also agree the patient stories are absolutely critical. We've got to be able to illustrate to people in the end what will be truly different, what will be the experience, and to describe that in a way that everyone can understand, both patients and staff. And co-production is going to be really vitally important to that. Again, I agree. The priority order has to be decided when we've been through the proper stakeholder engagement, but I wouldn't disagree that mental health, when you look at it, does seem in the wrong place, and even more so when you think about the impact on mental health of the COVID pandemic. Implementation is going to be a challenge, but again, as already described by Melanie, there's quite a few elements that are going to be important to the strategy are already well underway. And again, when we talk about timeframes, again, although the strategy may cover 10 years, it will be, the prioritisation will be part of this engagement process to decide what needs to be delivered in years 1, 2 and 3. And finally, smart objectives. I absolutely agree. We have to be able to say what we're trying to achieve and know that we can measure it. So I agree with that comment entirely.
Good. Thank you very much indeed, Bernard, Simon, everyone for their comments. I thought that was a really interesting discussion, and we'll obviously come back to this at future meetings, and in particular, of course, have a report from the really important programme of engagement with patients, carers, staff, including doctors, but a much wider group of staff and clinicians. And that will all be absolutely critical in informing this work. So thank you very much indeed. We now turn to our fourth major agenda item, which is the estates programme. Because as you saw, as you saw from the slide pack, very helpfully circulated in advance, it's a very complex picture here, and a lot of work needed and already been done. So I'm going to hand over to Mark Flynn. Welcome, Mark, from the CCG team, who's been leading the estates work.
Super. Good morning, everybody. Thank you very much, Patricia, for that introduction. So obviously, I will take the papers as circulated as read, but there are a few points that I would like to draw out to highlight to the partnership board. So firstly, we've got details included in this update of the system estates operating plan for the year ahead. We're looking to refresh our system estate strategy, which will be underpinned by the clinical and digital strategy. So just listening towards the end of that conversation on the clinical strategy, that is going to absolutely underpin what we need to deliver regarding the estates to make sure that it's fit for purpose for the future. Also in the pack are details of our funded capital investment programme, and that incorporates a new hospital rebuild for the James Paget, which was selected as part of the new hospital national programme. Development of 5 new primary care centres across the system, a new mental health inpatient wards at Helston Hospital, also the diagnostic centre, acute centres as well, the diagnostic centres, and all of these are currently at the early business case stages. Finally, just to draw to your attention is the issue regarding the rack plank issues, and I know there's been some attention on this and particularly some conversations in the media about it. I am now pleased to report that we have got some confirmed funding to support the mitigation works, and we're well aware of the issues at the Queen Elizabeth Hospital and its building, and work is continuing to take place to look at our full health and care estate just to make sure it is fit for the future. We also continue to work closely with both NHS England and NHS Improvement as a system to look at options for improving and enhancing our estate across the system, including the Queen Elizabeth. So those are the points that I wanted to highlight, and I wanted to leave as much time as possible for questions and interaction and discussion. So happy to take those now.
Mark, thank you very much indeed. And I'm very glad that you highlighted specifically the issue at Queen Elizabeth, because obviously we were all absolutely delighted when James Paget was included in the hospital building programme, the National Hospital Building Programme. But we really do need and want to see Queen Elizabeth included in the next phase of the hospital building programme, rebuilding programme as well. So, Melanie, I don't know whether you wanted to add anything to that, but then we'll take questions and comments from colleagues.
Yeah, and thank you, Mark. Thank you for pulling all this together. It's a huge piece of work, the estate strategy for the whole of Norfolk and Waveney, and there's a lot in here, lots of different funding streams as well, so it's quite complex. And I think, you know, just to follow on from your points around the Queen Elizabeth, I mean, we absolutely share the aspirations and plans, not just for the repair of the roof, but for the new build, and there is at the Queen Elizabeth, and you know, to get funding for that business case. So we do share those aspirations across the system, and that's really, really important. But nothing more from me. Thank you, Patricia.
Thank you very much. Let me come to Billboris.
Thank you, Patricia. I just wanted to support this and to say how absolutely vitally important it is. And I would also like to echo what Patricia has said about the putting pressure elsewhere nationally around the money for the Queen Elizabeth Hospital at King's Lynn. Just to say that the County Council and the district councils, who are obviously all part of this system, are also willing and keen participants in this estate strategy. We all know that, but I'd just like to emphasise that this is a strategy that crosses all partners, and they're all, say, willing participants. Thank you, Patricia.
Bill, thank you. And actually, that's a very important point, because I know from my own discussions with the district councils, because they've got that housing responsibility, actually having that very close engagement between planning for sometimes really major housing developments and then ensuring that primary care is available in the right place, you know, for those new residents of expanded housing. It's really important, and it's also an issue of concern to a number of our local MPs. Steve Barnard.
Thank you, Patricia. I just want to echo the thanks to Mark for all the work that's gone into this. I think having a strategic approach to the management of our estate is absolutely essential and sits very closely alongside the development of the clinical strategy for the system. And also to thank all of the partners for your ongoing support for capital funds for the building of a new hospital at the QE, which is vitally important, I think, to give additional impact to that developing clinical strategy. And a big thank you as well to the Health and Wellbeing Board of the County Council, who recently endorsed their support for the development of a new hospital at the Queen Elizabeth. Thank you.
Sorry, thank you, Steve. Any other questions or comments? Right, Mark, thank you again. You know, you and your team are doing well, and the team across the system are just doing a really important and great piece of work on this, and it's very good to see all the different bits being joined up. So thank you very much indeed for that.
Thank you, Patricia, and thanks for your input as well today. That's been really helpful.
Good. Right, well, we're actually ahead of ourselves on our programme, so that's excellent. And we come to questions from the public. Chris Williams, I think you were going to put up a slide at this point, were you, with questions that were received in advance?
Hi, Patricia. Jodie's just doing it now.
Ah, wonderful. Thank you. Okay. Thank you very much indeed to Chris for submitting those. I think the second one we've actually just covered in that discussion about estates. The third one actually has been touched on, I think, at several different points. And the first one, I think, you know, the clinical strategy discussion provides quite a bit of context for that. But what I would, as I indicated at the beginning, there will be a full answer to each of those questions, and that will happen within 7 days and will go on the website. Now, I'm just wondering whether, thank you, Chris, for that slide, or thank you, Jodie. That's fine, we can go back into the meeting. I just wondered whether any of the other colleagues who've been watching the meeting today wanted to raise a question. I know we haven't had any by email, but if anyone does want to raise a question relating to any of the items that we've discussed on the agenda today, you'd be very welcome to do so. Just use the raise hand facility if you would. We have one from Esme Corner. Esme, I'm sure Jodie can unmute you. Please ask us, just introduce yourself if you would for everyone, and then tell us your question.
I'm Esme Corner, I'm the lead governor from the Queen Elizabeth Hospital in King's Lynn. Thank you for inviting the public to be here today. Obviously, I'm particularly interested to be here. Governors are very keen at the Queen Elizabeth to be kept abreast of what is happening at the level of the ICS development. I wanted just to ask, do you foresee any role for governors in this forum? Probably something over 50% of governors in organisations are elected by the public. So we are the public voice. They're a group that we haven't heard about at all today, haven't heard them mentioned. And indeed, that's rarely the case that we are mentioned. And yet within our own establishments, we probably play a very significant part. I know that's the case in recent history, at least, at the Queen Elizabeth. So I'd be interested to see, to hear from you whether or not you feel there'd be any value to involve governors from all our organisations at any level in the foreseeable future. Thank you, Patricia.
Esme, thank you very much indeed. It's such a pleasure to see you here, and thank you very much for being here and for that question. And I agree with you. There's no doubt at all governors have a significant role to play within their foundation trust. I know you and the governors at Queen Elizabeth do that, but I know it's true of all of our foundation trusts across the system. And that will continue. That will continue, I think, as a very important part of the overall system. As far as the broader sort of architecture and design and all the rest of it of our statutory integrated care system from next April, again, foundation trusts will remain in being, and so that role for governors will continue. But I think your point also about governors being a voice for the public and patients, I think that's important. And I will just make sure after this meeting that our colleagues who are working on the patient and public engagement work also look to governors as a source of, you know, frankly, well-informed members of the public, some of them patients, some of them carers, to have direct input in that work. I don't know whether any other member of the partnership board would like to comment on Esme's question. Okay, thank you. Oh, Pip, yes.
It was really just to say that that certainly is a concern for the governors of NSFT as well, what role they might have. And I think that it's something that we probably need to address at some point.
Okay, thank you, Pip. Oh, lots of comments. Right, you've started something. Okay, let me take Steve, and then Anna, and then Melanie.
Thank you very much, Patricia. I strongly support Esme. I mean, I would anyway, but I do genuinely think that it would be remiss not to tap into the substantial experience and expertise that's embodied in our governors, and of course their direct links into patients and patient representative groups. And I think it's incumbent upon us to make sure that we not only provide a very good briefing service to our governors, but every opportunity for them to engage meaningfully in constructing this new architecture of an integrated approach across a broader system than individual providers.
Thank you, Steve. Anna?
Thank you. I think Steve's really just covered what I was going to say, so no problem.
Okay, fine. Melanie?
Thank you. Thank you, Esme, for the question. It's good to see you here today, and thank you for joining. It's a really important area that we will absolutely consider. I would just take us back to the white paper that was published in February. It's still very early days with what was published and what we now understand, and there were quite significant changes in the white paper, which to the way that we had been planning. In some ways, it was an evolution, but the main change to what we had been considering was that there will be an ICS NHS board as a statutory body, and also a partnership as well. So that was new, and we expect there to be further, more detailed guidance, which we will look at. I believe there'll also be local flexibility as well, so we won't be constrained by it. But I think that will be very helpful to guide our next steps. We expect that around April, June sort of time. And that will include things like the appointment of non-executives, as well as the involvement of other groups as well. So I think there'll be more for us to be able to say and discuss then, and then think about what local flexibility we might want to look at as too.
Thank you, Melanie. I think you meant May, June for the May or June for guidance as well as the bill. Thank you. I'm going to take Tony, and then we have a question from Councillor Mary Rudd. Tony.
Yeah, thank you, Patricia. In the past, I think we've brought together governors, non-exec directors, trustees in the old STP system. I wonder if there's some benefit in the future doing that again, because you look across that cohort and the level of skill, experience, and capability that there is there. Bringing, I think, that independent thought would be really helpful. And I know my non-execs are really keen to engage.
Yeah, and both Melanie and I spend quite a bit of time going to meetings of boards, but also meetings with a wider group of governors, non-executive directors, staff at our different trusts. And that's really helpful. The other thing which actually we should just mention in this context is our proposal for an engagement forum that will enable a much wider group of stakeholders and partners to come together within the work of the partnership. And I think that's going to be very important, and also reflects one of our principles, which is leadership at every level. This partnership board and the boards that succeed it when we become a statutory system are just a small part of the leadership of the whole system. It's leadership at every level. But let me welcome Councillor Mary Rudd from Waveney. Really good to have you here, Mary. Do please make a comment or ask a question.
Yes. Hi, thanks. Hello, everybody. I'm Councillor Mary Rudd, and I'm the Cabinet Member for East Suffolk Council. I was really pleased listening in today that Waveney has not been forgotten in all this, and I'm sure you would expect me to say that. But also, don't forget about our district councils and all the councillors on the ground who know an awful lot of what is going on and what people's feelings, expectations are, etc.
Yeah. Thank you very much for that point, Mary. As I said, I think in my report, over the last couple of months, I've been having one-to-one discussions with, I've now reached almost all the district and borough councillors around our system. And I know, having been an elected representative in the past myself, you've got that insight and deep understanding of the particular areas that you represent. And I think as we develop the work, particularly around health inequalities, it needs to be informed both by the data, the excellent data analysis that we get from our Director of Public Health at the county councils, but also by that insight and day-to-day intelligence that councillors and councils can add. It's really important in making sure that we devote our or prioritise the communities and areas that have been most left behind. Are there any other questions from people attending the meeting? I don't think so, and I believe nothing else has come in on the emails. So thank you very much indeed for that. I think it just underlines the value of meeting in public and providing an opportunity for questions and comments. So that brings us to our final item, any other business and approval of the dates for meetings for the rest of the year. You'll see on that we still need to confirm a date for December or January, and we will do that as quickly as possible. But do colleagues have any other business that they want to raise? Right. Well, thank you very much indeed. We've ended early, which was a great surprise. I must say I feared we would be overrunning given the weight of the items that we've considered on the agenda. But thank you all very much indeed for your participation today. And thank you to all the colleagues, members of the public, governors, councillors and others who've joined us at the meeting today. Look forward to seeing you next time.
Thank you, Patricia.
Thank you, Patricia. Take care.
Thank you.
Thank you, everybody.
Okay.